So everyone starts out with 100% beta cell mass or healthy beta cells. And over time, it starts diminishing. And then eventually, if you lose enough beta cell mass, then you become symptomatic. So we're now trying to identify patients much earlier in that process. And if you can identify it early enough, we're hoping to have immunotherapies or disease-modifying therapies that could delay the onset of needing insulin. And there's one that's already been FDA approved now that we are using if we can identify these specific patients.
Trying to make it in a way that's understandable to those outside of endocrinology.
Mhm.
You've got genetic propensities, but again, most of those people won't ever develop diabetes. And then you've got maybe the next step would be you have some of these autoantibodies, these antibodies that you can see that the body is starting to attack the pancreas,
Correct.
but still no symptoms.
Correct. No symptoms.
And then it can progress to blood sugar changes, but still no symptoms.
Correct.
And then it can become symptomatic.
Correct. Yes.
And pretty much to date, our only way of getting any insight was when it became symptomatic. But now you say we have a therapy that we can,
yes,
it's been approved.
Yes. So now we're trying to identify these patients, as you said, upstream. And these are patients who have the autoantibodies. So think of autoantibodies as just markers of the autoimmune process that's going on. Before you become symptomatic, remember now that you continue to lose beta cell mass, and then your blood sugars starts to increase. And if it's starting to become abnormal, that's when we can give this disease-modifying therapy.
And that's what's technically called stage 2.
Correct.
Okay.
Stage 2.
So stage 1 is you've got antibodies, but nothing else.
Yes.
Stage 2, you've got antibodies and some blood sugar changes.
Yes.
Stage 3 being symptomatic. And you say there's an intervention at stage 2.
At stage 2.
Okay.
To delay the onset of stage 3.